A very good evening to everybody from Singapore, from Japan, from India, and from Pakistan. From all of us, from the Ifso Apc, we welcome all you to this APC webinar. It's a great honor today. This webinar is dedicated to NASH and obesity and the role of bariatric surgery. We have two great speakers today. Mark Dinesh Mutaya, who is a senior consultant with the National University Hospital and the National University of Singapore, and his expertise lie and his research work lies in the field of NASH and obesity as well. Our second speaker today, who will speak on the role of bariatric surgery in NASH and NFLD, is Dr. Arun Sanyal. He is basically a professor of gastroenterology and has published extensively in this field and an eloquent speaker in this field. So to first kick off, I would like to say thank you to all of you for joining us. The recording of this will be available on the Ifso YouTube channel, as well as it can be on the Virtual Academy for Ifso. If you have questions, type in your questions into the question sections, and at the end of the session there will be we will answer these questions live. We have two basic videos that are recorded, and we'll play them one after the other. The first will be that by Dr. Mark Mutaya, who is going to speak on implications of the epidemic of fatty liver disease to us, followed by Arun Sanyal. We unfortunately do not have Arun Sanyal joining us today directly. He had a medical emergency, but however, Mark will be taking the questions on his behalf. So we thank you. I thank you all my moderators and the speakers for your effort today, and for all the participants to coming live today. So we shall kickstart the session. Thank you very much.
Good evening. First of all, I'd like to thank the organizers, the IFSO, as well as Dr. Asim Shabir for inviting me to give this topic on this talk on a subject that I'm very passionate about: fatty liver disease, NAFLD and NASH, the implications of the fatty liver disease epidemic. I'm Dr. Mark Mutaya. I'm a transplant hepatologist from the National University Hospital in Singapore. These are my disclosures. So for today's talk, I will cover the epidemiology and pathophysiology of the disease, prognostic markers and issues about liver-related outcomes, as well as extrahepatic outcomes in the disease, and broad concepts on management strategies. So why the fatty liver epidemic? So if you can look at this data which is taken from the US transplant database, we can see that fatty liver disease has become the top cause of liver transplants in female patients in the United States and is rapidly rising in male patients. Similarly, we see this in Singapore, where fatty liver disease, transplants for fatty liver disease, either liver cancer or liver failure, have overtaken hepatitis B as our top cause of liver transplants. Coming from Southeast Asia, fatty liver disease is highly prevalent in Southeast Asia, with a prevalence of more than 40%, which is one of the highest in the world. Not only is the prevalence high in Southeast Asia and worldwide, but it is rising, mirroring the global epidemic of obesity. So we do see 1.2 billion cases of fatty liver disease worldwide. This is really a significant proportion of our global population, with a 0.83% annual increase in prevalence rates all over. The age standardized death rates in Southeast Asia are 2.35 per 100,000 population. Interestingly, this mirrors caloric consumption. What can be seen is that in areas with high amounts of caloric consumption, the prevalence of fatty liver disease is higher, and inversely, in areas with lower caloric consumption, the prevalence of fatty liver disease is lower, emphasizing the importance of caloric overload in this condition. However, is it all just due to food and increased caloric consumption? Not really. Fatty liver disease encompasses a complex interplay of genetic factors, environmental factors, as well as the development of the metabolic syndrome. So some patients may be more predisposed to having genetic risk factors, where some patients may be more susceptible because of obesity or lifestyle factors. It is sometimes difficult to tease these patients apart from each other. So what is the pathophysiology of the disease? At first, there is nutrition and increase in amount and potentially even types of food that is taken in. Coupled with insulin resistance, these provide some of the environmental factors or as well as the metabolic syndrome. Now, what happens when the liver sees all this increased energy? Now, usually there are the regular metabolism pathways, and the liver is the center of energy metabolism in the body. Now, what happens is when the liver gets overwhelmed with calories or overwhelmed with energy, sometimes this excess energy gets bypassed, gets converted into bioactive lipids, some of which they can be toxic. These bioactive lipids or these toxic lipid species then can drive inflammation, apoptosis, and cell death. Now, the liver has a huge capacity for regeneration. And this huge capacity for regeneration, liver can usually heal. However, with chronic long-term damage, there are impaired wound healing responses, and the liver then develops fibrosis or hardening of the liver. So in general, the three key concepts in the liver that we look at are number one, steatosis, number two, inflammation, and number three, fibrosis. Now, as alluded to in the pathophysiology slide, we do have the progression from steatosis, inflammation, and then fibrosis. But how do we look at it in terms of the terminology? Any patient with any form of fatty liver disease can be said to have NAFLD or NAFLD, which is kind of like an umbrella term. However, the bulk of these patients have NAFL, which is the more benign form, which is just consisting of steatosis, no inflammation and no fibrosis. About 5 to 10% of patients with NAFLD have the progressive form of the disease, which consists of inflammation and subsequently fibrosis. This can then eventually lead to the development of liver cirrhosis or liver cancer. So how do we look at the spectrum of fibrosis? We grade fibrosis generally based on histology or non-invasive biomarkers, and we look at histology. If the cirrhosis is of grade 2 and above, so there's grade 0, 1, 2, 3, and 4. Grade 2 and above, we call it clinically significant fibrosis. Grade 3 and above, we call it advanced fibrosis. And anything above grade 4 is considered to be cirrhosis or meets the definition of the cirrhotic architecture of the liver. What is interesting is that the mortality, especially the liver-related mortality that we see, comes about only when the patients have grade 2 fibrosis and above. Liver-related mortality rises in patients with at least grade 2 fibrosis. So this is why clinically significant fibrosis is important to us and is important to intervene in these patients. So then what happens when the fibrosis progresses? So when these patients progress from fibrosis to cirrhosis, they then develop compensated cirrhosis, also now what we call compensated advanced chronic liver disease. And these patients may have mild portal hypertension, but may not have any symptoms and may potentially have varices. They then progress on to developing episodes of decompensation, which can be variceal hemorrhages or variceal bleeding, ascites or hepatic encephalopathy. And as they further progress, they develop further decompensation events which are a threat to life. Recurrent bleeds, refractory ascites, hepatorenal syndrome, hepatic encephalopathy that limits their functioning, as well as jaundice, potentially even acute or chronic liver failure, and finally death. So this is the spectrum of the disease. But what we kind of look at, what is important? Are we concerned about fibrosis for the sake of fibrosis? Now, if a patient were to have fibrosis and no impairment to their mortality and no morbidity, then technically, do we have to care about it? In the same vein, if they were to develop raised liver enzymes or inflammation in the liver, but this was not going to affect them, we wouldn't really bother too much about it. But what we are concerned is complications of the liver disease. And what can these include? These are liver-associated clinical events, which can include hepatic encephalopathy, ascites, variceal bleeding, or potentially even having a MEL score of at least 15, because this is generally when the patient would be eligible for liver transplantation. The patients can also develop HCC or hepatocellular carcinoma, which I'm going to talk a bit more about. Now, fatty liver or NASH is a major driver of liver cancer. Interestingly, the proportion of HCC that is caused by fatty liver disease or NASH is high, and especially in the Asia-Pacific region, where it's more than 20% of causes of liver cancer is actually due to fatty liver disease. But what is interesting about liver cancer in patients with fatty liver disease? Firstly, a number of these patients, in most liver diseases, they develop liver cancer only after they have developed liver cirrhosis. However, in fatty liver disease, patients can potentially develop liver cancer in the absence of liver cirrhosis. However, this is an area under intense research, and we have yet to see what is the optimal, or I won't say optimal, but what is the point at which they may develop it. Also, interestingly, if you data on the right side demonstrate that a smaller proportion of patients who were found to have NASH HCC were actually undergoing a screening program or a surveillance program. So, and this is important because these cancers can be missed and can present only when they are very late. Coupled with the echo bright findings that you may get on ultrasonography, this may mean that some of the cancers may be missed until they're really at quite a late stage, quite large, or asymptomatic. Now, we all think that transplanting the liver solves the problem. We solve the fatty liver disease. However, fatty liver may actually be a more systemic disease, as we realize that patients who have been transplanted for NASH have an altered metabolic profile even after the liver transplant. So now we move on to the multisystemic fatty liver disease, or MAFLD, not only affects the liver, but can affect the systems outside the liver. This can include the brain, the endocrine organs, the blood vessels, coronary artery disease, atherogenic dyslipidemia, musculoskeletal system. Of course, one may argue that a lot of these are associations, and given the high prevalence of the disease, then one is able to find lots of associations in the literature just driven by the high prevalence of the disease. However, some of these multisystemic effects do have correlation with the severity of the disease, some of which I'm going to touch on a little bit more. Now, with the previous slide that I have shown on mortality in fatty liver disease, I'd like to bring up another point. When comparing patients with early fibrosis, so just now we said patients with clinically significant fibrosis had increased liver-related mortality. But when looking at patients with early fibrosis, there's an increase in all-cause mortality, but not liver-related mortality. So what can we glean from this data? This is telling us that these patients actually are dying from something else. So what are they dying from? The top cause of mortality in fatty liver disease is actually cardiovascular disease. So as can be seen in these studies, the incidence rate per 1,000 years is 4.79. So this shows that these patients have cardiovascular mortality. So what do we mean by cardiovascular mortality? It can be atherosclerotic heart disease. And coronary artery disease or coronary heart disease has been shown to have a high prevalence in patients with fatty liver disease. But what is interesting is that with increasing degree of steatosis, meaning as the steatosis rises from moderate to severe steatosis, we see an increase in the prevalence of coronary heart disease. On the right, two separate cohorts, the UK Biobank cohort, as well as the Dallas Heart Study, have shown that the interaction of the visceral fat and the liver fat are correlated to outcomes, cardiovascular events. So this demonstrates the importance of liver fat as in the role of cardiovascular disease and cardiovascular events. So one would think, then should I be screening patients with fat in their liver for coronary artery disease? Currently, there's no evidence or recommendation for that, and it's still recommended to do routine risk-based scoring using things like ASCVD calculators. However, this area is under research, and we hope to see certain more refined guidelines potentially giving us more dichotomy on what to do for these patients. The second type of cardiovascular mortality, which is actually more common than atherosclerotic disease, atherosclerotic cardiovascular disease, is structural heart dysfunction. And what is interesting is the most common cardiac lesion in fatty liver patients is actually left ventricular diastolic dysfunction. And these have been shown to be independent of metabolic comorbidities. And the diastolic dysfunction correlates with fibrosis in the liver. So this is analogous to potentially having HFpEF or heart failure with preserved ejection fraction, which is a diastolic dysfunction. Moving on to obesity. Patients with obesity have a very high prevalence of fatty liver disease. Previously, we mentioned in the general population, it ranges from 15% to 40%. However, looking at patients who are obese or overweight on the left or obese on the right, we see percentages or prevalence rates of 70 or even 75%. And the rate of NASH in these patients is higher. That means the prevalence of NASH in these patients who have NAFL is higher. This means that the disease is more common and more aggressive in patients who are obese. Fatty liver disease is coupled closely with the metabolic syndrome, and diabetes is a two-way association. Patients with fatty liver disease have been shown to have increased incidence of diabetes and vice versa. Patients with diabetes having increased incidence of fatty liver disease. However, the diabetes also appears to be a disease modifier in a disease modifier if you look at it, with patients diabetics with fatty liver disease having a higher incidence of all or higher hazards of all-cause mortality. Patients with fatty liver disease also tend to have high blood pressure, and this is coupled to cardiovascular related mortality. And patients with uncontrolled hypertension do have higher risk of mortality as well. The second most common cause of mortality in patients with fatty liver disease, especially steatohepatitis, is actually extrahepatic malignancies. And some of these malignancies can be colorectal malignancies, breast malignancies, and potentially even stomach cancers. And this is why sometimes there are calls, and studies have even demonstrated increased risk of colon polyps in these patients and advanced adenomas in these patients, calling for more careful screening in patients who have fatty liver disease. The last thing that we'll talk about is depression in patients with fatty liver disease. This is a lifestyle disease. The major treatments, as we'll discuss later, are diet and lifestyle interventions. And psychological motivation is very important, but a large number of these patients are actually depressed. And not only that, the depression correlates with the severity of the disease. So what management strategies do we have for fatty liver disease? I'm going to cover very broad concepts. So firstly, we need to understand how to stratify patients with fatty liver disease. Ideally, the gold standard is to detect the inflammation as well as the fibrosis would be a liver biopsy. However, we can't biopsy every patient given that almost up to 40% of the population has fatty liver disease. So we do use non-invasive biomarkers and of course prediction based on certain metabolic markers. Non-invasive biomarkers can include blood tests such as the FIB-4 or the NAFL fibrosis score. Here we demonstrate an algorithm that shows stratifying patients into low risk with the FIB-4 of less than 1.3, high risk of fibrosis with more than 2.67, and indeterminate risk, which is in between 1.3 and 2.67. The FIB4, made up of AST, platelet, and age, is a simple, easy to use test, which is commonly available with routine blood tests. So what are there? There are currently no treatments licensed for fatty liver disease. No guidelines approve any treatment, and there are no approved treatments by the FDA or regular or most societies worldwide. The only treatment that has been shown to work is weight loss via diet and lifestyle intervention. And importantly, in the paired biopsy samples, patients achieving at least 10% total body weight loss by lifestyle management had a good chance of achieving not only resolute histological improvement, but fibrosis regression in the disease. So meaning the hardening, the key outcome that we are looking, regressed. However, it's very easy to say lifestyle modification. However, this is not successful in a large number of our patients, and a lot of patients did not perceive that their lifestyle contributed to their liver disease. So how do we advise for weight loss? Caloric restriction, potentially with professional help, not just by the doctor telling the patient, oh, lose weight in clinic. That's not going to happen. The second thing is teaching patients how to integrate the nutrient composition and caloric restriction into their diet. Thirdly, to avoid fructose and beverages and foods with high fructose, including things like fruit juice. Coffee has been shown to be beneficial. Exercise is good, although diet is better, exercise is still good, and supervised exercise programs for those with high risk of metabolic diseases. However, the reality is less than 50% of patients achieve a successful weight loss, and only a small minority of the 50% sustain that weight loss. And of course, there's cost issues. Food and eating healthy is expensive, and the social role of food is very important. Now, adjuncts to weight loss that have been FDA approved, weight loss agents, that FDA approved weight loss agents have potentially been tested but have not shown objective benefit yet, although some of the GLP-1 receptor agonists are potential hopefuls. What I'd like to highlight is in some of the guidelines for recommending weight loss, recommend for management of weight management in fatty liver disease. The role of weight loss and bariatric surgery programs has been highlighted in potential benefit. Prof. Sanyal will be talking on this later, so I won't talk too much on the role of bariatric surgery. However, I would like to touch on some of the drugs for NASH. In red, I have highlighted drugs that have been shown to have cleared phase 3 studies or are in the process of clearing phase 3, but not yet approved or have hopeful. Vitamin E, bile acid, FXR agonists, or targeting the bile acid pathway. GLP-1 receptor agonists, none of which are phase 3 data. PPI alpha, delta, or gamma agonists, as well as thyroid hormone receptor beta. Some of these drugs have cleared phase 3 but have not reached regulatory approval for treatment for fatty liver disease. However, we are close to having a drug for fatty liver disease. What is interesting is the drugs that potentially may help are drugs that target the metabolic component of the disease. This meta-analysis demonstrated that if the drug targeted the metabolic component of the disease, they tended to have a higher chance of success in phase 2 and phase 3 trials. So in summary, fatty liver disease is a disease with major implications and burden, and is defined and happens because of complex interplay of upstream drivers. And however, managing these patients is not just about managing the liver, but as well as managing the patient as a whole. And we need to know the extrahepatic associations. And importantly, treatments targeting energy overload and metabolic factors appear to be lead candidates. With that, thank you, and I'm happy to take any questions.
Well, thank you very much, Mark, for that great talk of yours. What we will do is we'll take the questions at the end. I think there's some questions that are coming over. We'll take them at the end. Manuela, if you could roll on to the next presentation by Dr. Arun Sanyal.
Hello, my name is Dr. Arun Sanyal. It is a pleasure for me to give this talk on bariatric surgery for NASH. Here are my disclosures. Before we start the talk, it is important to set the stage by talking about what NASH actually is. It is part of a spectrum of disorders that is associated with excess fat in the liver, called fatty liver disease, and by definition, it is not attributable to the consumption of alcohol. Thus, it is called non-alcoholic fatty liver disease, which has two phenotypes, a fatty liver or steatohepatitis. It is often associated with other comorbidities in the form of hypertension, coronary artery disease, heart failure with preserved ejection fraction, type 2 diabetes, and chronic kidney disease. And what connects all of these is underlying metabolic stress, systemic inflammation, and fibrosis. The root cause, of course, being diet-induced obesity. We recognize these as risk factors, but what they really are comorbidities. When you have one, it is likely that you'll have the others as well. So the leading outcomes in people who have fatty liver disease are cardiac, vascular, kidney, cancer, and liver-related outcomes. But because liver-related outcomes are relatively uncommon in the general population, when you do get liver disease, it has a major impact on the patient who has the liver disease. There are two critical concepts. One is the concept of disease activity, and the other is the concept of disease stage. Activity refers to the injury to the liver and is reflected under the microscope in the form of steatohepatitis and various disease activity scores, such as the NAFLD activity score. The stage is the consequence of activity and reflects the scarring reaction to the injury and is reflected by fibrosis stage. Now, fibrosis stage reflects proximity to cirrhosis and therefore is linked to liver-related outcomes and mortality. So in the short term, our goal is to reduce disease activity and/or fibrosis, and in the long term, to reduce progression to cirrhosis and clinical outcomes. We have learned over the last 10, 20 years that the key determinant of this outcome is indeed fibrosis, as shown over here, where patients with stage 3 and 4 had the bulk of clinical outcomes. But the outcomes start increasing right at this time of stage 2, and this is all-cause mortality. And the same is reflected for hepatic decompensation, which typically occurs primarily in those who have cirrhosis, as shown over here. So the objectives of today's talk are to talk about bariatric surgery for NASH and the special role of bariatric surgery in the context of cirrhosis and transplant, a couple of safety-related issues, and some emerging data on endoscopic approaches and future directions. So first of all, there's now a tremendous body of literature which indicates that in individuals undergoing bariatric surgery, cardiometabolic outcomes are improved compared to standard medical therapy. And this is summarized in this very nice systemic review in JAMA, where the proportion of people having cerebrovascular events, coronary artery events, and overall cardiovascular events are shown to be decreased. Now, moving on to the liver disease itself, there have been a number of studies with a variable number of patients ranging from as low as 11 to as high as 362 that have studied the impact of bariatric surgery, predominantly proximal gastric bypass or sleeve gastrectomy, but also some data with biliopancreatic bypass, who have evaluated liver histology before and after the surgery. Now, this slide shows the overall data on the impact on disease activity as measured by the NAFLD activity score, or the NAS, and shows pretty universally significant improvement, with the exception of Nobili's study, where there was some preoperative changes. But in general, the bulk of the data reveals improvement. Now, when you look at fibrosis, the results are a little bit more mixed. Some of it has to do with methodological details, and some actually do reflect the fact that some patients did not show improvement in fibrosis. And some insights can be obtained when we do a deep dive into the largest study, which is the French study from the group of Philippe Mathurin. Now, in this study, it's a retrospective analysis, and they started with over 1,500 patients, but found 109 patients who had NASH at baseline. So it's a retrospective analysis of prospectively collected data where they had biopsies at the time of bariatric surgery, with follow-up biopsies at a year out and subsequently. So eventually, 82 patients had a biopsy also at 1 year. So they had about 80% follow-up of these 109 patients. And as you can see over here, the majority of patients had a bypass. Some had a gastric band. Now, the following slide shows what happened to NASH before and after surgery. So the NASH grade evolution is shown and is color-coded over here. An important point here is that 85.4% of patients lost their steatohepatitis 1 year after bariatric surgery. Highly effective. Now, there were of those who did not resolve their NASH. What was the issue? So they took a deep dive and looked at this. And what they found is, if you look at the non-responders, NR, they had generally higher disease activity scores, lower baseline BMIs, and poorer metabolic dysfunction markers, as well as higher fibrosis stage at baseline. Now, when you look at fibrosis, remember, fibrosis is what links the liver disease to cirrhosis and clinical outcomes. This is shown in the following slide. So the data at baseline and after bariatrics at 1 year are shown, where you look at the distribution of fibrosis stage. And you see that after surgery, there's an increase in the blue bars, reflecting a greater proportion of people who no longer had any fibrosis. But this is primarily taken from those who had stage 1 disease, which improved, and stage 2 disease, which also improved. And these are the orange and the gray bars. Notably, the lighter orange bar, which is stage 3 fibrosis and cirrhosis, there was not a dramatic improvement. So when you looked at a year after surgery, and you looked at those who responded versus those who did not respond, it turns out that those who did not respond were, of course, as you might expect, those with the more severe disease at baseline, including more fibrosis. In another study from France, they looked at fibrosis evolution after bariatric surgery and repeated the biopsy several years out. And what they found over here, as shown in terms of persistence of severe fibrosis, is that 46% of those who had stage 3 or stage 4 fibrosis, this is bridging fibrosis or cirrhosis, continued to have bridging fibrosis or cirrhosis, even though the NASH and the activity markers had resolved. So the fibrosis does not magically disappear after bariatric surgery, particularly in those with advanced disease. So the question then is, what about clinical outcomes? Because in the end, what we really care about are whether you're improving clinical outcomes. And this is addressed in the Splendor study that was published a couple of years ago in JAMA from the Cleveland Clinic, a very carefully done study, and they looked at patients undergoing bariatric surgery who had NASH, and they compared them to non-surgical controls. And on the left, you can look at major adverse liver outcomes, which is clearly increased in those who were controls receiving medical therapy versus those who had bariatric surgery. And similarly, cardiovascular events was decreased as well. Of course, these are not randomized controlled studies. And so one caveat always is that there are selection biases that are not obvious using routine parameters that may be present that determine why somebody was a control and why somebody went to surgery. So there may be a selection bias towards better risk patients undergoing bariatric surgery that we need to be cognizant of. However, the data at face value is quite striking and shows an improvement in both liver and cardiovascular outcomes with bariatric surgery in patients with non-alcoholic fatty liver disease, especially NASH. Now, moving on to more advanced disease, patients who have cirrhosis. There has been some controversy about whether these patients truly do benefit or not. And so this was looked at in about 100 patients. This is a study from Indiana University. And the way they looked at it, because there were no controls, is they looked at the baseline MELD score, and they predicted mortality based on the baseline MELD score at 30, 90 days, and then at 1 year, and then looked at the observed mortality. And what they find is a substantial flattening of the score, which is very encouraging and indicates that in properly selected patients, one can successfully undergo bariatric surgery, and these patients have a less than expected rate of outcomes. Now, of course, the key here is patient selection. And it is very important to make sure they have adequate liver function, what their comorbidity profile is, and also their perioperative risk. And finally, whether portal hypertension is present or not, and to make sure they do not have hepatocellular carcinoma or other vascular issues that could become problems later on. There is no data to indicate that a pre-operative TIPS improves the outcome of bariatric surgery in this population. So if you look at safety, which is a big issue in the surgical population in patients who have cirrhosis, this is summarized over here. And you can see that in general, there's a low rate of complications, but you do have a profile of complications. But the data have some instability because of the one study from Pestana. Regardless, even if you throw those out, you do see that there's a certain number of patients who develop complications. And particularly in those who have decompensated cirrhosis, somewhere about a 20% rate of complications has been reported. And that brings us to the population of patients who have already decompensated and whether this is a reasonable option. So many of these patients are being considered for liver transplantation. And when they are being considered for liver transplantation, the outcomes are often affected based on their underlying obesity, but also in the long term by recurrent disease in the graft. So early studies started looking at sleeve gastrectomy prior to transplant and showed that not only could it be done technically, but these patients tended to lose weight, as shown over here. Similarly, then, things moved along, and there were a small series of cases where the sleeve gastrectomy was not only done prior to, but maybe even at the time of surgery. And in this early series from UCSF, where the median MELD was relatively low, so these must have been patients undergoing transplant for hepatocellular carcinoma, I'm guessing, that these patients did not have prior mortality and had a median weight loss of about 1 year. Now, there have been since then a number of series in the peri-transplant period where patients got their bariatric surgery before, at the time of, or after transplantation. And these are summarized in this table. And in general, majority of these patients did well. And it did have an impact on weight loss and metabolic risk factors post-transplant. So if you look at the post-transplant setting and you look at morbidity, you look at mortality, and you look at hospital stay, these data are shown over here. So there is a small impact on mortality, but these are not out of line with the overall mortality seen with transplant. And similarly, there is a morbidity profile. And so about 30 to 40% of these patients will experience something. And the proportion are shown on the right in numbers with this forest plot. Similarly, it is not clear that it has a huge impact on hospital stay either. So the main benefits would be long-term, and we need better quality data for these long-term benefits. The long-term benefits also have to be placed in context with risks. So there are some key concepts if you're going to undergo bariatrics in the context of liver transplantation. First of all, at each site, it's imperative that a standardized approach be followed with specific nutritional, activity, and weight loss goals. The weight distribution ascites are important for technical considerations, but these patients need very close follow-up. There is a substantial increase in symptomatic reflux. Also, further weight loss can occur post-bariatric surgery, and many of these patients are sarcopenic, and this may have a negative impact on their recovery. And later on, of course, they have to be monitored for regain. There have been some new innovations using intragastric balloons in the peritransplant period. The initial experience was reported from India, and it was very encouraging, where some patients were able to lose weight and then subsequently have undergone transplant. Since then, there has been another series from Mayo Clinic, which shows that these patients can improve. But the news is not all good. Once you remove the ability to eat and by restricting the size of the stomach, it can potentially lead to other issues. Many patients eat because it's a form of coping with stressors. And when you take away that means of coping and addiction to food, other addictions can come into play. And there is now a lot of literature indicating a growing problem of alcohol misuse post-bariatric surgery. And these are data shown, from University of Michigan, and these are data compared to patients without and with bariatric surgery, and in data in men and women, etc. And basically, the bottom line is that there is an increased risk of alcohol misuse after bariatric surgery. So these have to be evaluated in the preoperative phase and patients managed appropriately in the postoperative phase. Another major concern is this increased risk of suicide, which is also linked to the same issue. If somebody is coping for serious behavioral and mental health issues by eating, and you take away their ability to cope without offering them alternate approaches, you can throw people into a spiraling depression, and this can also have a negative impact. So these all will have to be factored in all bariatrics, not just patients with NASH, and have to be placed in context with the benefits as we develop a personalized approach to who gets bariatric surgery and how they get it and how they are followed over time. So I will wrap up with a few takeaways. First, that bariatrics is highly effective for the histological improvement of NASH and markers of activity. The effect of bariatrics on fibrosis evolution, however, is not as clear, especially in those who have advanced fibrosis, which may not move at least within a 1 to 4 year time frame. Bariatric surgery can be performed safely in those with cirrhosis, but careful patient selection is key. In the long term, clinical outcomes are improved, both liver and systemic, in those with NASH undergoing bariatrics for an obesity indication, because it is not yet an indication for NASH itself. And the role of bariatrics before, during, and after transplant is evolving, and we need more data in this space. I thank you for your attention.
Thank you very much for that lovely talk. Mark, are you there? Thanks, Mufi. Thanks, Kazu. And thank you very much, Mark and Arun. That was a great talk. I really enjoyed both talks. I think I will kick off the question session. Mark, there are patients, like we know for diabetes, the low BMI patients don't respond very well. Are we talking about a similar metabolic profile here? They won't respond to bariatric surgery?
So the NASH patient currently is quite heterogeneous, as mentioned in my talk as well. These patients can have genetic factors, can have metabolic NASH, metabolic risk. So in general, especially in Asia, we tend to see some patients having lean NASH, the phenomenon that we call lean NASH. And this, of course, then becomes a little bit challenging how you deal with this. Certain groups, I think an Italian group has put out the hypothesis of metabolic NASH and genetic NASH. So I think currently our definitions are all based on histology, but we haven't subclassified the disease well enough. But when we do, one would assume that those with more metabolic type NASH, as defined by the Italian groups, potentially may benefit a bit more from bariatric surgery, prevention of the energy overload as compared to the genetic component.
Thank you very much. Kazu, Mufi, and Cici, any questions, please address them.
I have a question. Mufi, you first.
You go, Cici, go first. Okay. I'll go next.
Okay, very good presentation. We all know the liver is the most important metabolic organ of the human body. NASH is also very common in obese patients. But NASH clinical symptoms are not worse, so very easy overlooked by bariatric surgeon. So I have a question. And bariatric surgery can treatment NASH completely or just remission. But most very benefit for patient. From the two presentation, maybe it's remission. And another question, the second question, NASH. You said is a driver of liver cancer, but in China, we usually is visual hepatitis, and also the West country maybe alcohol is a driver. I want to know which one is most important. If those there or if all together, if maybe is a very driver to liver cancer.
Okay, excellent questions. So I think for the first question, in terms of bariatric surgery and where can we see the benefit? So looking at the studies, we see a benefit in disease activity or the inflammation that we talk about. However, there has been limited benefits, at least especially from the two large studies from the French group, Philippe Mathurin's group, as well as the PI study. We see limited benefits in fibrosis. However, to be very honest, looking at all the NASH trial drugs, looking at all the phase 2, phase 3 clinical trials that we are running in NASH and the results that have come out, we see that fibrosis is really a very difficult target to see reversal in. And so this may be, the caveats to this is, have these patients been followed up long enough to see the reversal of fibrosis? Or is there truly a lack of reversal of fibrosis? But as Dr. Sanyal mentioned, I think one of the key things beyond the fibrosis, the inflammation, these are surrogate markers of outcomes. what is very important to see is benefit in outcomes, improvement in progression to cirrhosis, development of portal hypertension, development of liver cancer, and even extrahepatic manifestations of the disease. Currently, the data is not mature. And this is where maybe we can look at some of the limitations in the studies on bariatric surgery. Because when the studies were performed, even by the two large French groups and even the American group, the Prof. Ali Aminan's group, what we see is these patients did not undergo bariatric surgery for NASH. That means the a priori decision making wasn't, this patient has NASH, and for the NASH, let's go for bariatric surgery. It was almost like a post hoc, we send these patients for bariatric surgery, now let's go and look at their livers and see how they go over time. So what would be required is a study which a priori looks at NASH as an indication. Because if you look at a lot of these studies, the patients with fibrosis or significant fibrosis are actually quite minorly represented or minimally represented. So I think finally we still need data in terms of outcomes. And outcomes is key to all of us. Now, coming to the second question, very good question, because, and to put it this way, it is us hepatologists, it's our fault, because 20 years ago and 15 years ago, we were also concerned about viral hepatitis, hepatitis B and hepatitis C. And now we've got quite good drugs to either treat or control the disease. And suddenly we've all started realizing that fatty liver is the major burden, coupled with our obesity pandemic or epidemic and the rising burden. Now, you are very correct in that these diseases have to be looked. Your patient who has hepatitis B certainly can be obese and have metabolic risk factors. We do know that diabetes increases the risk of liver cancer in these patients. But so we know that it's an amalgamation of factors and not just the individual. So even now in our programs, we started saying that, a patient with hepatitis B who has metabolic risk factors, they need to start losing weight and improving their lifestyle, because they actually have a higher risk of liver cancer, especially if they have diabetes. So all these things have to be taken together as one thing. So currently, the problem is fatty liver, or NAFL is a diagnosis of exclusion, meaning you have to rule out Hep B, Hep C, alcohol. But in reality, a person who has metabolic risk factors may drink and also have hepatitis B. So this is where the challenge lies in. But we would label this one as hepatitis B because it's the easiest to label. But in reality, all of them can drive liver cancer.
Okay, thank you.
Would you go ahead?
Hi, Mark. Great presentations. Both of you all did a great job. So I've got two questions for you. One is that in those patients where there are certain malabsorptive surgeries that we guys do, there is a nutritional component that gets added on to the fatty liver, NFLD, or fibrosis. We already do know that fibrosis or cirrhosis doesn't improve post bariatric surgery, whatever you do. So would you recommend any kind of surgery which is malabsorptive in a patient with let's say a NASH score which is beyond a certain level? That's one question. And the second thing is that even in any bariatric surgery, there will be some degree of nutritional compromise. So would you recommend that they get monitored for X period of time before they are good to go and you don't see any decompensation? And the second one is in those with lean NASH, right, who have a normal BMI but have extrahepatic components of NASH. Would you recommend that these people see a bariatric surgeon much earlier because they have central obesity? Maybe they have causes to tell us it's metabolically induced NASH. So would you recommend it even at a much lower BMI, even when the BMI is not that high? Would you look at recommending these for early bariatric surgery so that you might prevent the progression towards fibrosis and eventually cirrhosis? Thank you.
So I think very good questions. I think the first question, in terms of the malabsorptive surgery, if you look at the PICE study that Arun presented, the one that was presented as a poster in 2019, the final study has come out, published in Gastroenterology, and subsequently we did a comparative meta-analysis based on that. And what you can see is that there are two types of, again, I'm speaking to a crowd of bariatric surgeons, so forgive me if I make some errors here, but we look at it as kind of like volume shrinkage, stomach shrinkage versus, you know, your intragastric balloon, sleeve gastrectomies versus your bypass procedures. And we actually do tend to see a slight benefit in terms of the histological improvement as well as the metabolic improvement in the bypass procedures. In the PICE study, and you can actually see that the biggest factor for improvement in fibrosis is if a bypass procedure was selected rather than just like a laparoscopic banding or sleeve gastrectomy. So I think that is interesting data. Again, it is based on post hoc analysis, but it's something worth further investigation. So this is the first point, and that's the current evidence that alludes to that. Now, the second point, we know that patients who have NASH and fatty liver disease, especially as the liver disease is more advanced, they have now what we describe as sarcopenic obesity. So these are patients who, you know, have a reduced muscle mass, and yet they are obese. So the BMI themselves can be high, but these guys actually have poor nutrition. And actually there are roles for specialized nutrition for our NASH patients in terms of meat-based proteins, so plant-based proteins, tofu, these kind of proteins, soy-based proteins, as well as specialized nutrition to help build these patients. In fact, in our transplant literature, especially for the slightly more advanced patients, we've actually started putting them on intensive prehabilitation, you know, these ERAS, early recovery after surgery protocols, as well as optimizing their nutrition. And we find that this helps. So we suspect that looking beyond at the sarcopenia, the muscle strength is very important. What we do, we have this thing to measure. We have various indices. We can look at the CT scan, look at the L3 cutoff. We have this UCSF frailty score, which makes use of a hand grip strength. And so dynamic and structural studies to look at that. But I would suggest if you're planning to take these patients for surgery, optimizing the protein nutrition and minimizing the sarcopenia would be very useful to help in post-surgical recovery for these patients. Finally, I think as to the last question, lean NASH. So I would say my summary to that is there's insufficient evidence. I think lean NASH needs to be more properly defined, given your cutoff for obese and overweight, your comparative differences between Asians and Western population. But you are right in that central obesity is the target, which may be difficult. Is there any role to refer them early for bariatric surgery? I think currently there's insufficient evidence. However, if they meet the traditional indications for bariatric surgery, I for one would certainly send them over, based on their BMI, their metabolic risk factors. And I think some of the other things is these populations really need to be studied a lot better. The problem is a lot of them come from countries where genetic studies, GWAS studies are not so common. And so our understanding of them is still not to the level that it should be.
Thanks, Mark. Mark, a few questions from the audience, and if you could take them a little quick. The first question is about, would you see any definite contraindication to bariatric surgery from liver side, from NASH, NAFLD, cirrhosis? Would you say that's an absolute contraindication?
So right now, I would say not really. I think a lot of these patients would be a case-by-case basis, and especially more progressive the liver disease is. But the data out of Indiana University that Prof. Sanyal presented was really quite interesting. because it's very sad that I will refer these patients to Dr. Asim for surgery, and Dr. Asim will turn around and ask me what's the risk of decompensation if I operate on this patient. And so we generally use the MEL score, the vocal pen score, or the Mayo score to give us our risk assessments. But one may say that I think there may be a benefit to a lot of these patients. So I think case by case, we look at things like liver cancer, timing to transplant, potential living donor transplant versus deceased donor transplants as for the later stage. And for the earlier stage, I would go for metabolic comorbidities, cardiovascular risk, pre-operative surgical risk. This is what I would consider.
Thank you. One last question. Do you find any role of bioimpedance in following up these patients with steatotic hepatitis and NASH? Do you think it should be done after bariatric surgery, or you think we are good with what we are doing? Thank you.
I think there may be a role. In fact, where we find what we have started to find is that there's some imaging, and this is purely in the research space. So I wouldn't caveat. I'm not putting it out there as clinical use. Is body composition imaging. And what we have started to see is very interesting body composition imaging. So for our research patients, we can pocket out, the visceral adiposity. We can pocket these out, and I think these are important for us. The muscle fat infiltration, liver fat infiltration. My guess is that this may have a good role post bariatric surgery, especially in these patients, to see how the adipose tissue depots, the muscle depots, as well as your visceral fat depots and the liver fat depots all interact. Yeah.
Thank you. Kasama, do you have any questions, any comments, please? Thank you.
Yes. So we know that the bariatric surgery is a very effective treatment modality for NASH, but of course, there is a point of no return regarding NASH. If the very severe NASH, even after bariatric surgery, you cannot have a remission of NASH. But of course, it's very hard to know where is the point of no return without biopsy. So what do you think is the modality to know that this patient is over the point of no return or not?
So, of course, yes, a biopsy would be the gold standard, but then I would recommend certain non-invasive tests. So if we are looking at fibrosis as a point of no return, a good surrogate to pick up from your clinic would be the FIB-4 score. But of course, the definitive, I would use an MR elastography, especially if the indication is liver-related outcomes. Similarly, if, for example, if not so much the fibrotic component, but the inflammatory component, there is now data that a type of scan looking at MRI of the liver, but looking at CT1, corrected T1, potentially can allude to the degree of NASH or steatohepatitis in the liver. So I would look at it like looking at a clinical trial in NASH, because if we are targeting the NASH, we need to adopt a NASH clinical trial mentality or NASH mindset. Currently, all the trials are biopsy-based because there's no approval, but we suspect in the next 3 to 5 years, the FDA will approve clearance based on non-biopsy based on non-invasive tests. And I think this is when a lot of our colleagues here, the bariatric surgeons, can use these non-invasive tests to kind of stratify based on some of these guidance recommendations.
Well, thank you very much. There's a lot to talk about, and there's a lot to go on, and we can go on. It's been an hour and a half close to now, so I think it's time to close the session. Before I close the session, I would like to thank our speakers, Dr. Mark and Dr. Arun Sanyal. Professor Sanyal, would miss you, but thank you very much, guys. Thank you to the moderators, Kazunori Kasama, our President CC Wang, and our ex-President Mufassal Lakdawala. So thank you very much, and thank you to that great little cute pet you have there, Kasama. I don't know what his name is, but hi to him. Thank you very much, and thanks to the organizing secretary. All have a good evening, and we look forward to seeing you at the next seminar. See you. Bye-bye. Ciao.
Thank you.
Bye-bye.
Thank you.
Thank you.